What we do at our hospital when we have any patient come in through the door, if they're here just for an appointment, meaning they stay with their owners pretty much the entire time, they're checked in, and all we will receive is a paper chart. This chart includes the client information, address, email, pet's name. Then it also gives the signalment of the pet. So this dog, we actually performed surgery on. She's a 6-year-old Yorkie Poo. She came in on a Friday with being obstructed, or possibly hadn't eaten in a few days. We ran lab work and did x-rays to try to determine what was going on with her. So during that amount of time, she ended up staying with us so that we could do our tests and investigate further. When a patient goes from being an appointment to dropping off, they get a cage card, which gives the client information, the patient information, and signalment. And then this cage card is in preparation for Monday. We're going to have this patient come in who will obviously not be allowed to have any food or water because we're going to do a dental cleaning and also remove a mass. They also get a neckband with their name on it that is attached before they leave the owner so that we can ensure that we have the correct patient. When we check the client in to perform the surgery, we will go through our anesthesia release form with them. What we have required on our form is the patient's name, age, the client must sign, and a date. Here, we give the informed consent of that the patient, there is always an inherent risk with anesthesia, the patient has up to date on its vaccinations, and that the client gives us permission to update any deficiencies at our discretion if needed. The client will fill out what procedure the patient is in for, what time did their pet last eat and drink. We allow dinner and then free access to water in the morning, but they will not have access to water once they're checked in here. We ask if they've had any health problems that we may be unaware of and to please explain. And then, do we have any known drug allergies? Next, we ask them to list us the medications their patient takes, the strength of the medication, dosage, frequency, and the last time given. Then we have a couple of extra questions on the end asking if they would like to have a home again microchip during this procedure. Did they ask for an estimate? Did they receive it? And then if they have, they check yes. If no, or they decline, they check that. We ask if you would like for us to contact you post procedure. Everyone says yes. And then we ask for a good contact phone number. The back side of our yellow sheet, this is our surgery sheet, will look exactly like the next one. This on the back side allows us to fill in the patient, doctor, technician, vaccines, and heartworm or FELV, FIV testing. The technician will fill this part out and say whether they're current or not, then list any other additional services. A lot of clients would like a nail trim while their patient is under, anal gland expression, etc. Outside lab that we use the most is the Antec. This is an example of a requisition form. We do all of our forms through the computer. So when we charge for something, a requisition is automatically created with Antec, and then the form will print off when we agree that yes, we want this for Antec and this is a normal case. This is an example of a late submission. We have 2 packages that we recommend for annual wellness. One we call an annual health screen, which is basically a 10 PC and a fecal and heartworm check for a dog. And we also, cats we don't do fecals on, and they don't run a heartworm check on them. We also recommend a comprehensive health screen, which is more than a 15 PC with electrolytes, a T4, urinalysis, and fecal. This patient received the comprehensive health screen, but we were unable to get urine from him at the time of the blood draw. So he's been boarding with us and we've been checking him frequently. He's a 4-pound Yorkie, so they're kind of hard to get urine on at times, and he's very shy and did not want anyone to watch him urinate. So we were able to get a sample via cystocentesis. So once we got that sample, since his lab work had already been sent off, we create a line item in Avamark for a late submission urine sample. This prints off We fold this requisition, take the urine that we received, and we label the tubes with the patient's name, the date, and the time that we collected it. And then we place it in this bag and then put it in our refrigerator. The Antec team that come and pick up our samples know which area the refrigerator is for them to collect our samples. If we have things like histopaths or cultures, they will not go in the refrigerator. We actually have, the form will be filled out. If it fits in this bag, the bag will have the form in it, the sample, as well as the bag, but then it will be clipped to the front of our refrigerator so that the Antec personnel know to take it with them, but we cannot store it in our refrigerator because it can skew our results. And then we will do our pre-anesthetic physical exam and make any notes there. We fill in the weight of the patient, temp, respiratory rate, heart rate, and respiratory rate, and then assign an ASA class. We will write down our induction agent. Here we use propofol. Gas is almost always isoflurane, but we do have the option for SIVO. The endotracheal tube size, we do not fill this out, nor the amount of propofol until we have induced the patient. We can measure and have an estimate of what size the endotracheal tube will be, but we're not always sure until we actually place the tube. On the other side, we calculate, once we have the weight, we change from pounds to kilograms. We calculate the emergency medication needed if something happens during anesthesia. So we would calculate the atropine and epinephrine dose. Once we go ahead and anesthetize, we start the anesthesia time. We have already calculated our flow rate for oxygen and the bag size we will use on our anesthesia machine. Once the procedure starts, we will put that time here. The technician has already filled out a lot of this. The next section the technician fills as well is if we're current, within normal limits, or if we need to update it today for the lab work. Because again, we require a minimum of used to be a 10 PC. With our HESCA machine, it's a 6 PC, which does our BUN, creatinine, ALT, AK, or alphos, total protein, and glucose, and then a full CBC. We will, once we've weighed the patient, done a quick exam, the doctor will do a full before we anesthetize. We will calculate our doses for pre-medication, and then we will go ahead and place our IV catheter. We will write down what gauge we used, where we put it, and then we will calculate the fluid rate needed, the antibiotic and pain meds, and this is where our pre-medication goes. How much we gave, where we gave it, and what time it was given. Then, once we're sedated and prepped and we're on the table for either surgery or our dental procedure, we will start our fluid rate and put our flow rate here and then the total given at the end. The rest of this is for monitoring for us during surgery. Every 10 minutes, we notate the information available. So we notate the time, the SpO2, heart rate, carbon dioxide, respiratory rate, temperature, blood pressure. We also add the mean arterial pressure, the MAP here. We have a Cardell, so that gives us this information during surgery. At the end, the doctor will put any notes that he needs, he or she has. The technician won't make any notes. And then the next morning, post-op, we will do a TBI to make sure that the incision looks good and or bandage, depending on what the patient had performed. Their temperature is good, they're bright, alert, reactive, have an appetite, etc. Then we will check down here so that the receptionists know where we are with this patient. So this is a blank form. We have our pink form, which is for our dentals. So this varies because outside of the previous requirements for lab work, ECG, fluids, etc., we also ask our patients, our clients, permission for dental radiographs, antibiotic gel, extractions, if they're okay with home medications. We used to have Oravet, we don't anymore, we just have not updated this yet. And then we have the same questions at the bottom, which are, would you like a home again implant? Did you get an estimate? Would you like to be contacted? If so, how? Once that's turned over, you'll notice that there are some things varying, but barely any difference here, because we require all the same information for both anesthetic types. The only change here is that we have the doctor's technician's notes together because there aren't very many variances when it comes to a dental cleaning. So again, this patient is a 10-year-old standard poodle. He will be in to have his teeth cleaned and a mask removed. When the technician checks this patient in, we go over all anesthesia forms with the clients the morning of the procedure. We must give informed consent when we have the anesthesia form filled out. This is our time to answer any questions the client may have. It also allows us to verify what mass or what limb or what area the patient is in for. We never want to run into a client asking us to remove a growth on a right shoulder and we don't confirm, and somehow we end up taking something off of, sorry, that was the left shoulder, off of the right hip instead of the left shoulder. So we always ask our clients to verify what location this is at, and to make sure we're all on the same page. We want to make this as smooth of a transition as possible. We are paperless, so we have Avamark system. We are actually paper light, hence the paper charts that we have. The way that we try to, or the way we can remain as paper light as possible is having our monitoring and all that on the back of these sheets. We will staple everything together, and then the patient form, or the chart, if you will, that's here, would be backwards because we would have the anesthesia form attached this way. This is, again, a patient that we've already seen. I wanted to show you the couple of different forms that we get and use through here. Again, this is the patient chart. This is what starts a room. Then we gave an estimate to the client for the workup for diagnostics at the time. We work it up, we give a range of how much it'll cost, and then discuss with the client what we're looking at. This is the lab work that we ran in-house. For this patient, we actually ran what we call a 15 PC with electrolytes because she was inappetent, weak, had a low temperature, was very rotund, and this dog should have been about a 10-pound dog, and she weighed in, I think, at 16 pounds. So we needed to make sure that there was nothing going on or that was not obvious to us. We also ended up doing radiographs and an ultrasound and sending that out to a specialist. Because of the problems that we had with her, we scheduled surgery for the following morning, which was a Saturday morning, which we typically don't do. But she was fairly emergent. We did not have time to perform the surgery on Friday, and the owners opted out of seeing a specialist. Due to some fluid retention in her abdomen and her low hematocrit, we ran another hematocrit or packed cell volume pre-surgery on Saturday morning. Her gum color was very pale. She looked a little worse than she had been the previous night. Her packed cell volume remained steady, but due to the ongoing issues, we graded her as an ASA class 3. Outside of this incident, she's been a very healthy patient. The doctor we discussed which grade she really should have, and he felt that she was not as grave as she could be and felt that she was at a 3. You can see how we account for waste. This is our doctor's handwriting, by the way. So he pulled up 3 mils of propofol but only gave 2, so he wasted out 1 mil of it. We ended up pre-medicating this dog because of her ASA and what was going on. We pre-medicated her with cefazolin and also morphine because we have no other medication on board right now. During surgery, we gave her more cefazolin and 2 injections of dobutamine. Her heart rate dropped dangerously low. We ended up removing her spleen, which weighed about 5 pounds, and then parts of her liver while we were there. Due to her ASA class, she was monitored throughout the day until discharge. We kept a really close eye on her immediately post-op. We had patients ready for blood donation if needed. And she did very well and went home, and we will see she was transferred. She didn't go home. She was transferred from here to our emergency clinic for care over the weekend, and we anticipate her to return on Monday. Once we're finished with this patient tomorrow for our dental and mass removal, our post-op instructions will vary depending on what type of closure the patient has, the location of the mass. Most of the times we will usually keep external sutures on a mass removal. That way we can ensure proper healing. Sometimes there's a subcutaneous layer and an external suture layer. Most dogs and cats tend to not be very good about leaving their incisions alone, so we usually recommend an Elizabethan collar and or clothing of some sort to protect the incision itself. So if the dog has a growth on the back of the neck or the shoulder, we would recommend, and it's somewhere that the dog's face could not reach, we would recommend keeping that area covered but dry and clean. We also recommend that patients post-op are kept as calm and quiet as possible for the next 5 to 7 days, even if it is just a small mass removal, because we want to ensure that the patient doesn't extend and stretch the skin in any way. We want to reduce any chances of having a seroma. We have seen our fair share of seromas throughout the years, especially post-spay. We've seen a lot of people that take their pets out to play fetch running a day after they've had an ovarian hysterectomy, and then come in with a swollen area that is a seroma due to improper post-op care. If we send them home with an Elizabethan collar, the only time the patient can have that removed is if the owner is 100% watching the patient. Typically, the proper fit of an Elizabethan collar allows the patient to eat and drink properly with no obstruction, so there's no real reason why that e-collar should come off. We recommend that they come in about 5 to 7 days post-op, depending, to have our incision checked and or suture removal. We've done a couple of drains recently where on our discharge instructions, they're printed up and they come out on the client's receipt, but we also go over with the client to keep their pet quiet, to feed them small amounts of food and water after they go home the day of surgery. If it's a surgery that requires them to spend the night, feeding and drinking is as normal, but we're going to recommend that they still monitor their appetite to make sure they don't have any issues with diarrhea. Most patients go home with at least a minimum of an NSAID of some sort. Cats, we end up using either Onzi or the NSAID for kitty cats, or we send them home on buprenorphine, which is an oral medication that we give for pain. Dogs, we tend to send home on a few days worth of Deramax. Smaller dogs, we tend to send home on Metacam. We also have an NSAID called Galliprant that we use for patients that have some liver or kidney issues. This NSAID is a little gentler on the system and is less stress for the patient. If they go home on antibiotics, we will explain to them the antibiotics, the dosing, whether we've given any doses yet, and what to expect as we move forward. If we have something like a drain in, we recommend that they keep the drain clear and clean. We also recommend the patient not touch or lick or scratch out that area. They'll return in 3 to 5 days, usually about 3 to 4 days, to come in for a drain removal, as long as there's not really very much active draining occurring. And then we return in about 10 days post-op to come back and check our incisions and see if we can go ahead and remove the sutures. If not, we will return a few days after that to do the removal. None of these returns cost the client any money. They're part of our surgical plan, so the only cost is the client's time. Sometimes if you only need a small amount of blood, and depending on the cat, some cats seem to prefer to have the cephalic views instead of the medial saphenous, due to them having to be lateral and sometimes held on to. So again, we're going to go with kind of a less is more. Like with the dog, the restrainer will roll in between the elbow joint and then go lateral with it so that we can visualize the vein better. Good boy, George. And then you have TB syringes that aren't lure locks. Alright, so we're just going to insert the syringe and draw a little bit of blood. Good boy, George. So there is his cephalic. Good boy. This is our back. Go for the saphenous. We'll do the jugular last. So we're going to lay George on his side laterally. So there you go, George. And unless he makes us, we're not really going to scruff him or anything. We're just kind of pet him that way. And the restrainer is going to push with her right arm, push the top leg up and then karate chop down onto the leg that's on the ground or on the table here. So there you go. And George has tons of hair, so I'm having to, there we go, having to try to find it through all that hair. Alright, so I'm going to extend the leg fully. Good boy, George. And there we go. The restrainer's going to put some pressure where we drew. Let's do a jugular draw on a cat. Try to get this side if possible. Sorry. You want to restrain your cat, hold the legs together if possible, and then stretch the neck some to give the person drawing the blood a clear field. Going to put some pressure into the thoracic outlet and then insert the needle bevel up. Oh, Georgie, it's right there. Like it flashed. And there we go. Blood. Sorry. Draw some blood from 3 major locations on the dog. This is Rourke. We're going to go and draw blood from his cephalic vein, his jugular, and then his lateral saphenous. So my assistant here is going to distract him. You want to do it? There you go. So when drawing blood, your restrainer, which we don't need a whole lot with Rourke, he's typically a pretty good boy, is going to wrap her thumb into the elbow joint and then rotate out so that we can occlude the cephalic vein, like so. Hi, Rourke. You're gonna make sure your needle is up this way. And notice that good job. Notice she's put her hand between her and his neck and kind of pressing him lightly against her body. That helps him remain still. While he eats that, we're going to go back to our lateral saphenous. So this vein, on a lot of dogs, you can see easily, but when occluding it, it might get a little difficult. So with this, you're going to, for lack of a better description, kind of karate chop behind the patella. And with my dog, I noticed that if I actually rotate up a little bit with it, his lateral saphenous vein pops out a little bit better visibly. So go ahead and do that, Heather. So just kind of put your hand there and kind of rotate a little towards you. There you go. So it's almost like rolling it like we would for the cephalic. And this vein is a roly-poly, so you have to have a little bit of patience as you get here. There we go. And we got blood. Good boy. You dropped your pretzel. So for the jugular, the restrainer will hold the head up, and I'm going to go for his right. So I need you to bring his head down just a little bit, because when we go too far back, the muscles will hide the vein, and then have him look a little over his shoulder. So then you'll press into the thoracic outlet. Good boy. And it pops up right there. Good boy. And there we go. Who's a good boy? And that is a jugular draw. I'm going to demonstrate how to get a dog safely in and out of a cage. You want to open your cage door first, and then go on, Mark. Hey, go on. Go on. Good boy. You can go ahead to start closing the door as you remove the leash so that the dog does not dart out and we don't get anything stuck inside the door, paws, tails if you had one, etc. In order to get the dog out of the cage, you're going to slip your hand in with the leash and tighten it, and then allow him to walk out. So apply a muzzle onto a dog. Muzzles are obviously used for patients that are cautious and animals that we're unsure if they're going to bite or not. With animals in pain, even if they've never bit before, they are a higher risk of biting you. So with a muzzle, for proper application, you want to make sure it's big enough. This is a brachycephalic breed, so you have to be very careful when you're using muzzles because you can actually make it to where they can't breathe at all. The more brachycephalic they are, the more they need to be able to pant. Depending on the tightness of the muzzle, you may stop that ability. So the shorter side of the muzzle goes on top, and then the lower side goes under the jaw. You wrap it around the back of the ears and snap it. So work, sit, or look at me, one of the two bugs. Hey, sit. Okay, so again, you snug it over the top like so, snap the thing, and tighten it to make sure it's tight enough that the dog can't remove it. Now, if he needed to pant, he still could. We're going to demonstrate how to apply the Elizabethan collar. We keep a few e-collars on hand for patients that may only need it overnight, and instead of having the client require one and purchase one, we can just kind of do a quick fix while we're here. So that's why this one has multiple sizes with Velcro on both ends. For the Elizabethan collar, you're going to slide it up underneath the patient so their head pokes through. And then you're going to align the Velcro to where it fits best for the patient. So this one, you want to make sure that you can get, and this one's a little snug where I've got it right here, but you want to make sure you can get at least a finger, preferably two underneath. I like to take some gauze wrap and actually thread it through the ends of the e-collar and then through the collar as well to kind of hold it on just in case. But again, this is used to prevent the patient from licking at any injuries, incisions, sutures, staples, etc. And then when you take it off, you just voila, and they're free. I'm going to do a pre-anesthetic exam on Jeffers here. The technician will just kind of, we like to keep our hands on the patient and look for any major abnormalities. Hi, Jeffers. Hi. At a minimum, we always do a TPR, get their temperature, their pulse, and their respiratory rate. In a cat, for me, it's easier just to kind of hang on to them and count and distract them at the same time. Jeffers is a little overweight. I feel your pain. So I actually have to put a little more pressure on his chest than normal just to be able to make sure that I can feel his pulse properly. So we'll start counting. Alright, so we got a heart rate of 40 in 15 seconds, so 40 times 4 is 160. Absolutely normal on a cat. Cats have a higher pulse rate. And let's go ahead and get his respiratory rate. His tail is flicking. He's starting to run out of kitty minutes. Alrighty, good boy. Does that feel good? Yeah. Ooh, you got tickles? So his respiratory rate is at about 12, so that's 48 breaths per minute. He's purring, so it made it a little difficult to count totally. And now we're going to get his temperature, so Tara will kind of hang on to him and give him some love. We're going to lubricate the thermometer. as you're petting him, you're also feeling for any abnormalities in these scabs, lumps, bumps. Temperature's 101. Anything that you might want to bring to the attention of the doctor. And then we're going to take a quick listen to his heart and lungs. Okay, buddy. Very rapid rhythm. Good boy. All quadrants sound nice and clear. His heart is nice and steady. No arrhythmias or murmurs heard. He would be an ASA class 1 as well. So now we would go ahead and put in his IV catheter and then pre-medicate him for his anesthetic procedure. Pre-anesthetic exam on this patient. Every patient has to have an exam within 24 hours of their anesthesia. We would obviously have the veterinarian would also do an exam, but this kind of gives us a chance to evaluate the patient and notate any abnormalities to let the doctor know about. So what we do in the beginning is we TPR. So we get their temperature, their pulse, and their respiratory rate. You can get your pulse and respiratory rate by using the stethoscope, or you can use your hand. More times than not, we use our hand. Good girl. I like to use the femoral artery to get the pulse. And you just count. And we count for 15 seconds. So that was 25, and multiply 25 times 4, and we get 100. The normal heart rate for a healthy adult dog can vary anywhere between about 100 to 150 to 60, depending on how excited they are. Money is a very calm dog. This is one of our doctor's dogs, actually, so she's quite used to being here. Next, we would get her respiratory rate, which you can, are you panting? Hi. Let's not pant for a second. If your patient's panting, you can kind of stick your hand underneath their mouth and distract them, and then you will start counting again. Thank you. All right, and that was 11 for 15 seconds, so her respiratory rate is 44, which again is absolutely normal. We're going to lubricate the thermometer and get her temperature. I know, mon ami. Say, ooh. Girl, I know. Once we're complete, once we finish getting her TPR, we're going to take a listen to her chest. 102, completely normal. We want to make sure we don't hear any abnormalities, crackles in the lungs. So everything put together, she's an ASA grade 1. We would go ahead and put in her IV catheter, give her her pre-medications, and then get ready for her to be anesthetized for her procedure. These are the things we require. We require pre-anesthetic lab work, which is checks our liver and kidney values, glucose, total protein, and a CBC. We also require on a dog that they have an up-to-date heartworm test and are current on heartworm prevention. We also require IV catheter and fluids and ECG monitoring during surgeries and any anesthetic procedure. Propofol, we titrate so that we can use the least amount possible to intubate the patient and then maintain on anesthesia. We pre-medicate. This varies. For most of our procedures, we pre-medicate with clindamycin as the antibiotic, and then hydromorphone as our pain medication. With the current opioid shortage, our pre-medication for pain has varied. Currently we have morphine because we cannot get anything else. We prefer not to use morphine. It can burn when we inject. It also can cause vomiting and nausea, and that's just not a good thing for patients. They also tend to be a little more queasy post-op. If we're doing an abdominal surgery on a healthy patient, we also recommend doing a Cerenia injection, which is for nausea and vomiting and lasts for 24 hours. Add our surgery patient onto our surgery log that also counts as our controlled drug log for our surgical patients. So we'll put today's date, the patient's name. She's a canine. Her last name was Meyer. She was 48.8 pounds, spayed female. We did a laceration repair. She was pre-medded with morphine. We gave her 0.23 mLs. And then we used propofol. And we pulled up 6 mLs, but we only used 4. So we're just gonna write 4 mLs and then waste the rest of that. We're gonna use the initials of who performed the surgery and teched it. We write down our surgery time and anesthesia time. The repair only took 20 minutes. And she's up and doing great. At our hospital, we also have a mark for when we turn on our oxygen. We know not to fill it past our line pressure gauge. We have a maximum of what we like to have full. As you can tell, we're getting dangerously low, and we'll need to swap this out on Monday before we start doing any surgeries. This is our gas vac. It actually is our exhaust. We always make sure we turn that on after we turn on our oxygen tank so that we can make sure that everything is evacuated properly. Our anesthesia machine is connected to our oxygen line here. We have oxygen lines in every room in our surgical area. So this is our treatment room. We have an oxygen drop here. We have one here, further over in the dental area, one in our radiology area, and then of course in surgery. So we make sure once our oxygen is on, we connect our tube. What happens is that the oxygen will come in through into the flow meter and then output into our vaporizer. We use isoflurane. Before we do any sort of procedure, we always need to check the level of our isoflurane. And as you can see, this is getting a little low, so we're gonna refill that before we put any patient on it. Once it leaves the isoflurane vaporizer, it comes out into our fresh gas outlet. This outlet leads to these unidirectional valves. The first valve is for inhalation. We have a Y circuit connected here. So air comes out this way, and then the patient is hooked up to this tube here, right there. Then when the patient breathes out, this unidirectional valve will open for exhale. We have our pop-off valve back here. If we must always leave this open. If you have it closed down, this will allow gas to build up and can actually cause patient injury. So make sure that your pop-up valve is open. If you were to use your flush valve over here, say you wanted to fill the reservoir bag or to do a test on your machine, you must first close off your pop-off valve. Then you would press your flush valve. Now, if you use your flush valve, you don't need to do it when a patient is connected. Using your flush valve actually bypasses your anesthesia, which will lower your concentration of isoflurane and make your patient lighter than they need to be. So the flush valve really should only be used when we're testing our system. Down below here is our reservoir bag. So as the patient exhales, a mixture of CO2 and isoflurane sit in here. That's why it's called a reservoir bag. Some can be inhaled back in. And then we have our soda lime canister that collects our CO2. We monitor this and change it. And then obviously we have a date here of when it was last changed. If you see any purple in here, you need to go ahead and test your soda lime to see if it's still able to perform its job. You would open your canister, press on some of the tablets. It should crush fairly easily. If not, your soda lime needs to go ahead and be changed out. On the back side of your pop-off valve, this tube actually connects to our exhaust system. So I'm gonna slowly go around so I hope I don't make you sick. We have our exhaust system starts here, gas inlet. We had the vacuum set to low or high. We have it set to high. I'm gonna come back around. So it comes through this canister, through this gas vac first, and then it follows the tube up to our exhaust. Now, in our x-ray room, depending on where our anesthesia machine sits, we may not be able to reach the exhaust there. So we also have a passive exhaust system here. Let me focus in, there we go. So if we were in an area that we did not have proper exhaust hooked up, then we would replace this and connect everything for this passive. If we use our passive exhaust instead, we need to ensure that we replace it so that it always works properly for us. In addition to endotracheal tubes, we also have a box that we use for fractious cats sometimes and other pets. This is just a Rubbermaid container that we have a lid, and then we have a port here that we attach the patient to, and then we would turn on a high rate of oxygen and the ISO would go up to 5 so that we could basically gas them down. The patient is always under observation when this occurs. The other option are masks. This is about the largest one we have. The patient's nose goes in here. This end attaches to the anesthesia machine, and again, you're using a high rate of oxygen and your ISO is going to be as high as possible so that we can induce and anesthetize them. The size ranges from this large one for a large dog nose. We have medium-sized ones and even T90 ones. If we're inducing something, say a bird, we would use a washcloth or something like that to clog any holes between the patient and the mask, so we would have less waste when we're using the gas method. In order to connect our non-rebreather to our anesthesia machine, this is something we use for very small patients. Anything under 5 pounds we recommend, or it is recommended to connect your patient to a non-rebreather. So this is our non-rebreather circuit, and we're going to connect it. This end right here will actually replace the tubing for the fresh gas outlet. We'll connect that there. Next, this part will attach to the endotracheal tube on the patient. There is the reservoir bag for the non-rebreather. This blue line will then come and be plugged into our gas back here, and then the gas input, we would remove that and then connect this one, because then it is connected to our exhaust system and will be pulled through that way. Leak check on the machine. We're going to close our pop-off valve. We're going to fill our reservoir bag with oxygen. And we want to fill it until our pressure manometer gets to about 40. And I have it blocked here. So we want to hold it And as long as the gauge stays at 40, we're good and we have no leaks. And I can slowly release my hand. As you can see, it will drop then. So we are leak free. We currently just mainly use it for our heart rate and our SpO2. So we're going to put some lube onto this sensor. This goes into the rectum. And we'll see if we'll pull it forward a little bit more. Now, the difficulty of having it in the rectum is that the dog's anal tone can actually push it out, and then when they are fully anesthetized, the lack of anal tone will make it difficult for it to stay in. So there's our SpO2 with heart rate. This patient is fully awake, hence the high heart rate. But this is the monitoring that we use when we initialize the anesthesia and then prep the patient for surgery. This is our esophageal stethoscope. We're going to insert this down into her esophagus to get a heart rate. This is another portion of our monitoring. You can kind of get a rough estimate of about how deep this will go to try to line up approximately where her heart would be located, and know that you shouldn't go any further than about here for her. So you will open the jaw and then slide the tube in, and it will slide in easily since we already have the trachea blocked off with the tube. And as you go, you'll hear the heartbeat and then start counting. And then we'll write that down on our sheet as well. And that's it. While that's happening, we're going to choose our endotracheal tube size. You can line up your tube either here, perpendicular to the nose, so it's parallel between the two nostrils. Usually that gives you a good guesstimate as to whether the tube will fit or not. This is a 7.5. Perform a leak test on our endotracheal tube. We're going to take a container of water, submerge the tube with the cuff into the water. We have syringes that we mark to inflate the cuff, and then we're going to inflate the cuff and watch for any air bubbles to come up around the cuff, which would indicate a leak. If there was any air bubbles coming out, which there are none, then we would discard this tube and then test a new one. So we're going to do an ECG on this patient. We're just going to do a 3-lead here. When we set these up, there is letters at the bottom that tell you how to connect this, but it's fairly simple to remember. White is always right, meaning the right arm. So I'm the patient and he is right lateral. You're going to take this clip, good boy, and connect it just proximal of the elbow, and then smoke over fire. So that means the black lead will be on the left arm, again, just proximal of his elbow. And then the red lead will be on his left knee. Let me put that back up there. Just proximal of the knee. Then we're gonna spray some alcohol on it, not saturating it, but just enough to get it started. And we need our patient to be as still as possible. Our CO2 monitor also monitors our respiratory rate, and that is how we can keep a count of how much carbon dioxide is coming out as well as what the respiratory rate is. which is what we log onto our anesthesia form. Alright, so to help with staunching the bleeding, as we assist the doctor, we're going to take some gauze on some hemostats. And then repeat as needed. To take up blood pressure on our patient that's waking up from anesthesia, you want to make sure you have the appropriate size cuff, which we just kind of have a thing here, and we measure across the tail to make sure that we've got a good spot. It even tells you where the artery needs to be when you attach the cuff. So we're going to go ahead and Velcro the cuff on, making sure that the arrow is pointed at the artery, or against it, really. Then we're going to turn the machine on. I have moved this. We also use a Doppler. So here, you choose dog, and then you just hit start. The beauty of this machine is that it actually will give us both diastolic and systolic, as well as a heart rate and a map. So we get a little bit more information. We're still adjusting to this, so if anything reads strangely, we will resubmit and we will actually perform with a Doppler instead. All right, and there's our reading. That's it. We're getting our patient set up for surgery and putting the rest of all of our monitoring equipment on. We want to make sure that we get a rectal temperature. And the temperature is something we lube here, but it's something that we want to monitor every 10 minutes so that we can ensure that our patient is warm enough. We do have a water warming pad underneath our patient. We turn them on when we first open up, all right, and that's completely normal. So we will log that and then check it again in 10 minutes. We'll be placing an IV catheter on our patient here. First thing you're going to do is shave the hair so that you can have visual access of the vein. Because he's super hairy, we're actually going to shave all the way around. And possibly shave the holder's nails while we're here.
And now you're gonna sing. You can melt, Toby, it's all good.
Let's see what we're working with here. I gave you a bit of a chicken leg, didn't I? Let's make that look a little prettier. Alright, then we're going to clean it. So, I'm going to use scrub. Should have brought that vacuum in here. Alright, toasters. I'm going to use some alcohol to push back the upper hairs. Alright, so we have our scrub, which is chlorhexidine solution, and then alcohol. So you have to start in the middle, and then work your way out. Toby, you're being stained pink. He has such a short leg. Alright, and number 3. Good boy.
hang on to his leg for a second. Open up the catheter. We also use a cap here. Alright, so you want to make sure that you go ahead and release the catheter from its container. And I like to loosen that as well. Alright, Toby. Alright, so I'm going to use the thumb of my left hand to kind of rest against or near the vein. You want the bevel up on the catheter. And you want to just insert. And we get a flash. So we're going to feed it through. Actually, going to go ahead and screw in. Alright, dang it, if you'll just kind of put pressure there for me. Just thank you. Alright, so we're going to take our tape, sticky side up, slide it up underneath here. We're going to fold the tape over. And Toby and all his hair. He's a good boy. And I knocked that off. Let's just stick the tab right there. I'll clean you up in a second, buddy. So let's kind of make that a little prettier. Next piece of tape. Sticky side down. We will overlap here. Make sure the catheter is snug. Good boy, Toby. And then I'm going to swap out the lid for this. And then I'm going to flush the catheter to make sure that's good. Yep, good to go. It's a saphenous catheter, so we're going to shade the area. The skin's fairly thin in this area, so I like to push my fingers up into the groove so I can hopefully prevent nicking anything. Prep the area with some chlorhexidine and alcohol scrub. We're going to do a 3-time scrub. Ooh, it's cold, huh? Yeah. No, it's cold, isn't it? One more. I'll start in the middle and then roll out. Good girl. All right. Good puppy. All right, now the restrainer will occlude the vein so I can see it running right there. For placement, always loosen everything from the packaging. Alright, so make sure you have double side up. vein can roll at times. Alright, and she's going to hold that off. Cap in. I'm going to take some tape, half of a 1-inch piece of tape, sticky side up. Good girl. Roll it through. Gotta stop moving, girlfriend.
Easy, baby, you're okay. Come on.
Good puppy. Not the prettiest tape job again, but make sure I peek that tape. Didn't get it long enough for her wide leg. Note the end is tabbed there. Get our next piece of tape and slide it up underneath. This one is tabbed as well for easier removal. Now we're going to attach our port here. Because we usually use a needle while we're doing IV fluids for anesthesia, I'm actually going to tape this on. And we will flush. And good to go. And then we'll apply some vet wrap to keep it covered. And we will induce her with this later. To administer injections, both IV, hi, subcutaneous, and intramuscular, hi. This is one of my preceptors, Kristen. Wave, Kristen.
Hello.
She is an LV2 who went through Cedar Valley as well.
Do you want me first?
Let's do IV first. So the first thing we'll do is IV.
Sit.
Good girl. Yeah. Tolerant children. IV access, you want to use some alcohol, have your syringe ready, bevel up. And we're in. This is just normal saline because we induce via our IV catheter. Next, you're a good girl. We'll do a subcutaneous injection. So we just kind of lift the skin. This is your right shoulder. Insert the needle and squeeze or push. Good girl.
Can we see the other side?
Yeah. Good girl. And for her IM, you're gonna feel around and get into the meat of the muscle and inject. So we're going to sedate this dog for surgery. She actually is an ASA class 3. We've already started her IV fluids earlier. We're going to slowly titrate this, give about half. And if possible, if she's relaxed enough, we'll go ahead and intubate her with the least amount of propofol possible.
Okay.
Yeah.
Hi.
So pull the tongue out, visualize the epiglottis. There you go. Insert the tube. Hand is out. I'm going to go ahead and turn on the oxygen. so I can hear that it's already placed properly with the deep breath she just took. We're going to inflate the cuff. The cuff had a little bit of room in there. It's not a snug fit. Our cuffs have a balloon at the top too, so we can keep a better eye on how full something is. I'll give her just a hair more and then turn on her ISO. And then we're gonna put in, you good, our eye loop. We've already shaved as much as we can. I'm gonna go ahead and push some more. For another mil. Hopefully this will be enough to keep her down. All right, before we start our scrub, I've already shaved the area for the spay. We're gonna palpate the bladder, and if it's full, we're going to express it. And her bladder is pretty full. So since we're not on a tub sink, we're gonna go ahead and just express it into this towel so that it doesn't make a mess. This makes it easier on the surgeon, so they have a little bit more room in the abdominal area. And it's a slippery sucker. All right, there we go. I'm going to prep for a canine castration. Our patient is already under intubated and on anesthesia, and we have our ECG going. So to prep, you want to basically shave the entire abdomen similar to what you do with the canine spay. Just in case the doctor needs to make a wider incision for any reason, you want to have a large field that is sterile. I'd be very careful around the scrotum. The skin's thinner and it tends to nick more. So we're just going to lightly go over that area. He has a little bit of matting here, so I'm going to go ahead and shave that down. And then you want to try to make the shave as even as possible. Clients appreciate when you take the time to even things out. Now we're going to get our vacuum and remove all the excess hair. Instead of a lab coat, we use a non-sterile gown to finish the prep, and then before we move into surgery, we will remove it. Alright, so now let's even out his hair a little bit more. Always make sure your blade is as flush with the skin as possible. Otherwise, you will give them razor burn. Alright, so now we're going to do our first set of scrub. We call it the dirty scrub, to get off any excess hair and skin. The dog's dirty. You would do it a minimum of 3 times, swapping with chlorhexidine and then alcohol. You want to prep in the center and then work your way out. And I'm going to go ahead and spray some alcohol on his hair on the outside to kind of keep that in check. Hairy dogs, hair seems to come from everywhere. Alright, now alcohol again. While we're doing this, you want to make sure that his heart rate and SpO2 are still in line. Make sure that you have your anesthesia at a good plane. He's got a little bit of hair that came out, so let's do this one more time. Okay, now he's ready to be moved into the surgery suite. Alright, so now we're going to move him into the surgery suite. We're going to disconnect him from the machine. And when we carry him, you want to maintain sterility. So we're going to place him onto our surgery table, reconnect him. We use a ventilator in here. The vent now. So we're going to tie him to the table and then do our final prep. So he's a short dog, so to move our hooks where we attach the arms and secure the legs. Loosely attach this one because that's where his IV catheter is and his fluids will be running through there. We don't want to block that. Make sure that when you attach or tie the legs that you tie them evenly. Turn his ISO up a little bit. Tighten this down some more. We're going to start with our scrub. I'm going to start in the middle again and work our way out. Alcohol. Okay, now we're gonna finish hooking up all his monitoring equipment and get the doctor. So, monitoring our spay, this is our SurgiVet unit that measures the ECG, CO2, SpO2, and then we have our blood pressure cuff set up. We monitor every 10 minutes and then we notate our readings here. We added a spot for our map. We still have about 5 minutes before we'll do the next reading. But this is something that we monitor continuously, but then we notate it every 10 minutes. And we also do a rectal temperature, which we'll do in a moment. Connect your ambu bag to perform CPR. You would disconnect from the flow meter here and attach the connection here. Your ambu bag then is connected to the ET tube that is placed inside the patient's trachea. We're going to use George here just as an example. Once the patient is intubated, the tube is secured, we would inflate the cuff. The patient would be lateral. One person will be giving breaths, approximately at least 10 per minute. Here, the person doing chest compressions would cover about a half to a third of the chest, and then you would squeeze on the chest, doing about 100 to 120 compressions per minute. Then you would administer any emergency medications and continue on until the patient recovers, or you are told to cease and desist. So we're going to scrub in for surgery. Our faucet control is down here. My nails are already trimmed. I don't have any jewelry on. So I'm going to go ahead and open up our Chlorhex impregnated container. I'm going to move this for now. You want to get the whole arm and a little bit above your elbow. You just kind of put your soap on at first. And then scrub lightly.
Heard you had some crazy cases.
Yeah,
I think maybe the best trip ever.
that's good.
Yeah. That's what you really need to do. So we stayed on the boat the whole time. But it was just 20 people.
Oh, so you stayed on it like we did. You slept on it. I guess that was rough with them.
You can't live on the island. So there's only like 2 or 3 that's inhabited and the rest can't stay on it all.
So when you're scrubbing, contact time is important.
The rule is
Where I'm leaving the soap on the other areas while I focus on the other one.
look at all of it, 23% can have any kind of complication.
You want to make sure you
And,
clean all of your fingers.
we
This
both
soft
go
plastic
out of the house.
bristles on this brush can get up underneath your nail bed fairly well.
And we go out in the morning, go for a hike, and then buy alcohol and
While I let it sit for a little bit longer, I'm going to get
6 pounds. Well, I was hiking and smarting, and I thought,
my
well,
nail
I
pick
did all this, I'm gonna walk away, but
and remove any debris that can be under the little nail I have. You're never really fully clean. Skin can never be sterile.
Yeah, so there's only cabin,
Go that way. Alright, now we're going to rinse.
but I don't know where the rest of big enough to have quarters like you mentioned, and like the captain had a bed right behind the captain's area.
Okay, Rich, you want to make sure that soap and water, as you go to dry, comes off of your elbows, not your fingertips.
These are all the ones out of my voice.
And that's
I
that.
only had one.
You're going to let the water fall off of from your fingertips to your elbows. Now to dry your hands, I've already opened my gown pack and then I've got my gloves ready to go. So I'm going to actually pick up this towel that's here, and it is here so that I can dry my hands and remain sterile. And you want to make sure that when you dry, you do not go back over where you have already been with your towel. So we're going to make sure our fingers are nice and dry. And then I'm going to use the inside to come to the elbows. And then we're going to go to the outside and drop that away. Now we're going to grab our gown and lift it out. Slide our hands in. Making sure to keep your hand in the cuff, like so, because we're going to put our gloves on with the closed method. So with the closed method, you're going to take the cuff of your glove and this gets easier as you do it more often. Unfortunately, I am very slow at this. Take your glove, put it to where the fingers are facing down your arm. Place your hand inside. Pull up my fingers just a hair. Then I'm going to pull my gown down some. My pinky is a little stuck. There we go. All right, glove number one. Now we're going to repeat the process here. You can put it to where the fingers are facing down your arm, and you'll tuck your hand in. Pinky out. And there we go. And we're ready for surgery. Didn't have my mask on. And I'm sure you can see that. So we're all scrubbed in for surgery. I'm going to open the pack for our doctor. I have to apply one of the towel planks when we get ready for that. So we're going to apply the drape onto the patient. You want it one way or this way?
So one way. Yeah. That'd be good.
Alright.
Right there. That's good.
Alright. Straight, right? Alright, so to help with staunching the bleeding, as we assist the doctor, we are going to take some gauze on some hemostats. And then repeat as needed. You can see. And it looks like we need a blade. So we're going to get a 10 blade to load the handle.
Why don't you turn it around and do it this way? Yeah. Do it the other way.
This way, right?
That's good. Yep. Okay. All right.
Come on. Alright, so we're going to load the scalpel onto the handle now. Or blade.
It is kind of ugly tumor.
We're going to pass that to the doctor.
All righty. Thank you.
And I'm going to pass you some gum forceps.
Okay.
Alright. Post-op, we actually fill our a surgical bowl full of water, and we use Dawn detergent, a mild detergent, for our instruments. We open all of our lock boxes and allow it to soak. Then we actually use toothbrushes to ensure we get all debris out. Rotating it. And rinsing them. We move them over to a lint-free towel to dry. We use a instrument cleaner and lubricator in our ultrasonic machine that will vibrate and heat up. We let that run for about 5 minutes with everything open so that it will clean anything else off of, such as, since we don't use distilled water, it will remove any remaining detergent that may be there, and then lubricates all of our instruments at the same time. I've prepped our cat for a neuter, and the doctor is about to start the procedure. And that's it. We've moved our patient into the surgery room. We are prepped and ready to go for the surgeon to perform the feline spay. This is another of my preceptors. This is Dr. Armstrong.
Hi.
Hi. We're going to sedate and intubate our spay. So we use propofol. We've already pre-medicated. Hi, kitty. We already place a catheter so that we have IV access. We're just going to give about half. You're a good puppy. Give her a few seconds. Take it. Go ahead and push through us.
Yeah, push a little bit more. You wanna-
Oh, yeah, if you're ready.
Alright, so you visualize the epiglottis. And there we go. You got the big noggin. Alright, so give me a deep exhale, please. So we're gonna go ahead and turn on our oxygen while we deep breath. Girlfriend, can I have a deep breath, please? She says no. No. The other thing we do once we're finished with surgery is we clean everything down. We have moved our, we have taken our water heater blanket off to clean. It is plastic, so there's no absorbency issues there. Using chlorhexidine. Just to make sure we get everything nice and clean. We prefer our patients to be on some form of padding, so we have our padded thing covered with drape and then taped up, and then this is another piece of padding. Our water blanket goes here, and then we just cover it with a towel, which that will be, the water blanket will come back before we're doing our next surgery. After we've made sure that everything is clean, we've sprayed our instrument trays, everything else that needs to be cleaned, then we sweep the room. And you want to make sure that you get any dust bunnies or loose fragments. When we're in here and we're sterile, there is always a chance that something will happen where you would break sterility. As someone that scrubs in to help assist the doctor when needed, your hands must stay above your waist at all times. Anything above your shoulders and below your waist is considered non-sterile. So you must always keep your hands in front of you and not touching yourself. Then if, say that you were cutting and somehow popped one of your gloves, you would need to replace them immediately. Here we have multiple versions of the same packs, and then we even have certain instruments in pouches ready to go. So we actually had one of the covers for the lights fall off during surgery, and it landed on our instrument tray, and that was an unsterile device. So we had to replace the entire tray and open a brand new pack. If you dropped an instrument, you could do a flash sterilization, but again, we just keep extras of our packs and just open a new one. We can always wash and prepare a pack. We'd rather do that than worry about anything else. So I'm gonna throw this away and then we're gonna mop. have our mop and bucket that is only for surgery. That way we don't have to worry about any outside contaminants. Sometimes our surgeries can be quite bloody, say a spleen removal. And when we experience that, blood can honestly go about anywhere in here. So we always make sure that all of our walls, the ceiling, the floor, things, even our oxygen supply, are cleaned and kept clean, because you never know where something can land, especially when you have body fluids. We then move over to our, it's kind of old, our machine that has instrument cleaner and lube inside. We make sure that everything is open. This gets cleaned out once a week. It's diluted with distilled water as well to the manufacturer's recommendations. When it starts to get full, you close the lid. It's going to get loud. Our surgery packs, after we've cleaned all of our instruments, put them into our ultrasonic cleaner, which also lubricates them and allows them to dry with all our hinges open and everything unlocked. We will then place them all together for our pack. We always start off with our drape. Now, I know we need a small drape because our towel clamps are smalls. So as we do with our surgical towels, we fold in an accordion fashion. We actually fold all of these when they come out of surgery, out of laundry, which is why they're kind of already have seams on them. As you fold, you always want to ensure that you don't have any fibers, hair, or anything like that on the drapes or the towels. And then we will use the accordion fold to get it ready. We also have gauze here, a blade, and then a indicator strip for the autoclave, so that when we open it, we know that it was fully autoclaved properly. Now, we will assemble everything. I like to put all my curved instruments together and all my straight instruments together to try to make the best fit possible. It's difficult and a very fine balance. Rotate this a little bit more. For everything to fit and not collapse as you start to fold it down. I arrange by size, so that the smallest are always on top, or the shortest, if you will, the longest are on bottom. These scissors are a little thicker, so if they go on top, they're so heavy they tend to lop over. And then we've got our curved hemostats and our towel clamps over here. The car malt's already lined up. Keep in mind, everything is still unlatched. No boxes are locked. The only time they're locked is when the surgeon is using them. Everything is sliding off. Just gonna stick the scissors here for now. Then I try to push them all together as much as possible. You're going to take your gauze, blade, an indicator strip, top it off, move that blade in a little more, top it off with your drape, and then we're going to do an envelope fold. Our hospital does not use this technique, so I had to make do with paper drape because we do not have the appropriate towels or in order to accomplish this. So I apologize for the messiness that I'm about to do. You're going to fold your closest corner up and then fold it back so that you have a tab. You will take the next corner, sort of similar to wrapping a present, but you want to try to keep it as neat as possible. So the next corner, tab there. Now we're going to the far corner and fold it towards me. And I will rotate that back. And then the far right corner will also fold. Like so. Again, I apologize. I know it's not pretty. This is much easier with the appropriate fabric. Again. I'm actually going to tuck this corner in on the side as well, and then turn it this way. It's not pretty. We will use our autoclave tape to keep it shut. If I had a beautiful fold, it would tuck in itself. And then we would write what type of pack it is. All of ours are major packs. Small drape. The date that it's made. And the person who made the pack. That way if there's anything wrong, anything missing, they know who made the pack so that we can make sure we don't repeat the mistake. So we're going to fold our surgery gown to get it ready to autoclave. You're going to make sure that the outside facing surface is up on the table. You're going to take your sleeves and straighten them out along the seams at the shoulder. Then you're going to take the near side, fold it to the midline. Come back around to the far side. And again, fold to the midline. Make sure you straighten your shoulders up at the top. Then you're going to fold it halfway. Then you will third like an accordion, lengthwise. Then we will fold it accordion-wise. Ensuring that the ties are on top so that the surgeon can open the pack, pull the ties, and drop the gown out without contaminating it and remaining sterile. We're going to fold a hand towel that we're going to put into our surgery gown pack. This is used for once that you're scrubbed in, you can dry your hands with a sterile towel to remain as sterile as possible. So we fold lengthwise. And as you're going, you always want to make sure you inspect the towel for any hair or debris or cotton fibers, etc. Once you have folded it that lengthwise, then we accordion fold it. And this will go on top of the gown when we make the pack. Now we're going to wrap our gown pack that we've made. We're going to take the gown and the hand towel that we have already folded. We're going to add our autoclave sensor here. This will, once autoclaved properly, will turn black and it will become okay with an arrow pointing to it. This is to ensure that the autoclave has properly penetrated through the pack. So to do so, we will take our wrap here. Take the side over, keep as tight as possible. Fold it back. Actually going to tuck this in here. The final step, we take our autoclave tape, which from afar looks like regular masking tape, but actually has faint white lines that you can see. We're going to write on our pack what it contains. We only do a single wrap for our gown, so we're going to mark it a surgery gown. Single wrap with today's date and the person's initials as to who made it. Then we will take this tape and seal the gown shut. And then we will place it into the autoclave. This is our autoclave. It already has pre-programmed cycles for us. We do make some adjustments to it with the speed of how long it takes to dry the instruments themselves. We do bi-weekly maintenance on this machine. This is a drain tube, so we actually pull this tube down and then allow it to fill a bucket, and then we will fill this valve with a mixture of distilled water and diluted product called Speed Clean. We run that through an entire cycle, and then we drain it again, and then we wipe out the inside of the autoclave and everything, and then we refill this with distilled water so that we can autoclave again. It has a gauge here to let us know whether or not we need to add water. If it's red, we need to add more. Green, we don't. So we already have some packs that I just pulled from the autoclave. You can see that they have the black stripe, which means that the autoclave worked properly and we met sterilization requirements. We're going to go ahead and load in just the gown pack that we just made. And then we're going to close the door. For packs, the setting gets up to 250 degrees. The heating process takes about 14 minutes to get to the preferred temperature, and then it takes about 30 minutes for sterilization to occur. Total time to complete dry is usually about 74 minutes, but we have it set for 30 minutes so that we can, so it's about a 60-minute cycle so that we can have it ready to go faster. So we will just select packs. You can see that it lists the temperature 250 degrees, 30 minutes for sterilization, and then fast vent 30-minute dry. And then all we do is press start, and it will fill the chamber, and then it seals the door here so that as it heats and the water boils and the pressure gets up to about 27 psi, it will maintain the pressure and heat required to do proper sterilization. I'm going to remove some staples on a patient. He had an injury a while back that we've been letting granulate in, but he still has some surgical staples in place. Obviously, it's completely healed where the staples are located, so we know it's safe to go ahead and remove them. So we just insert our staple remover here and press down, and it will remove the staple. And then we'll repeat that on the other side. Good boy. If I can. He's a little chunky. All right. And there we go. And that's that. Both are gone.